from our members. And in case anyone of you have questions, please do post in chat box and I will take it up. And I'll be using Dr. Lopa, as I said, कि हिंदी इंग्लिश हम मिक्स करके रखेंगे because we have a vast set of audience. So we all know that how common breast cancer incidences are, not just in India but all over the world. And the thing is, most of them are getting detected in very early stage. So today's session will be about breast cancer treatment, and not exactly treatment, but post-treatment. Uh, what all options we have and what kind of queries we have. But before I come to today's topic, I would like to introduce our group, CSI, uh, Cancer Survivors in India, and this is a Facebook group which was started in I think 2017, if I'm right, and by Savan. And after that, I mean, Mehul and Amit, they have taken it forward. And today we have around 3.3 and more than that members. And the motive of the group is to provide guidance, support each other, and in whatever way we can help and be there for others. And yeah, there are few other things also right now in process which we are trying to do. For example, this is our new initiative where we are calling not just survivors but doctors and other speakers who can give us the awareness about different kind of treatments and cancers and questions we are having. And in that series only, today we have our esteemed uh, speaker, Dr. Lopa from Breast Cancer Hub. And before I hand over to her, I would just like to introduce her in few words. And Dr. Lopamudra Das Roy is the founder and president of Breast Cancer Hub, is a distinguished cancer scientist, research professor, a social entrepreneur who resigned from her rewarding career in 2017 to create Breast Cancer Hub as a full-time pro bono voluntary service, saving lives globally by making impactful, sustainable changes, working at the grassroots level, bridging the gap between the developed and the developing countries. Dr. Das has 20 plus of years of experience in research, teaching, and mentoring undergraduate and Ph.D. candidates in the field of genetics, breast, and pancreatic cancer. She is Ph.D. in molecular biology from Assam University, India. She received her post-doctoral fellowship from Mayo Clinic College of Medicine in USA in Cancer Immunology and MBA from Northwestern University-Kellogg School of Management, Chicago. She served at the University of North Carolina at the Charlotte as a research professor, and she was awarded with grant as Principal Investigator from the Department of Defense Cancer Research Program and National Cancer Institute, investigating targeted therapies and signaling pathways in cancer, worked as a research director at OncoTAB, and her research work is attributed with high impact factor publications, inventions, press releases with global recognition from American Association of Cancer Research and Press for breakthrough work on discovering the signaling pathway between breast cancer metastasis and arthritis. So Dr. Das Roy has won many awards, global awards, notably 100 Global Women in Leadership, one of the 5 inspiring women around the world leading the fight against breast cancer, received USA President Lifetime Achievement Award for commitment to building a stronger nation through volunteer service, Global Role of Cancer Awareness Awards, and the list goes on. Dr. Lopa. I mean, it's such an interesting. One minute, I'm just admitting few people. Yeah, I mean, it's such an impressive. There is so much behind what Dr. Lopa is doing, and personally, I know her from last 3 years. I have worked with her, and her work is amazing. Her knowledge is very, very deep, and I'm sure today the audience are really going to get a lot of awareness, and I think it's going to be very much interesting session. So, Dr. Lopa, it's all over to you. You can start, and maybe if I see that we are crossing the time, I mean, time there's a time limit, then I'll just interrupt so that we can wrap up quickly and can have a interactive Q&A session.
So what is my time limit, Savita?
So it's 5:10. Will have 30 minutes more roughly. I mean, roughly, I'm saying. So we'll try to. I mean, India time. I'm saying 5:40. We'll try to wrap up, so that we can have other questions from the audience.
Yeah. Perfect. No, thank you so much, Savita, actually for introducing me to CSI. I feel really honored, and everyone, I feel like I'll be learning so much from you all, because life's best experience gives the biggest learning, and that's what I feel. So please let it be an interactive session afterwards too, and I'll take all the questions at the end. And Savita already sent me a few questions, so I tried to incorporate those in the PowerPoint from the beginning. If even then it's not addressed, please we will have a direct conversation. So thank you everyone for your time today, for inviting me. And I'll just share my window. Uh, Savita, you.
Please keep, yeah, yeah. So please, everyone, keep yourself in. Deepa, can you please mute yourself? I'll just also. Yeah, mute. Everyone else, please keep yourself in mute. Yeah, Dr. Lopa, we are good to go. I think we
Okay,
can see
so
the
you
screen.
can see the full screen, right,
Yeah,
Savita?
yeah.
Yeah, only
Yes.
problem is with Google Meet, I can't see anyone. So it will be like I'm presenting to a blank, like.
Yeah, that's a little challenge.
Yeah,
Yeah.
but I'll start with I'll be very quick, because I'll try to give you a glimpse of the new, because a lot of questions I have seen has come based on, like, we are going through this treatment, for example, cat cycler, so what would be the other treatments. So I have incorporated everything that would be like, that is basically now FDA approved. And how I went is, so today's presentation will be, first of all, I'll talk a little bit about, what is the role, like what actually happens with cancer, and this will help you to understand what is going on in the body. Because even when someone is in the stage 4 or advanced stage, when you reach out to me, I find that the basic knowledge somewhere is missing. Because if you understand that, it will help you to understand what that where the treatment is going to work in your body. So I'll walk you through that phase, give you the new treatment modules that has come along, and also talk about the follow-ups, and how to prevent or how to work with the relapse situation. So that will be the framework for today's session. So before that, little bit of the statistics, and as you mentioned earlier, Piyush, right? So about the male breast cancer. So I'm going to talk a little bit about male breast cancer also in the beginning, but this is the statistics which is from the American Cancer Society. And you see that even in the US, we are estimating this many cases of female breast cancer and 2,710 new cases of breast cancer in men. And you can see that the expected death ratio for male breast cancer is 530. So just imagine if in the US, this is the scenario where with the women breast cancer, with the female breast cancer, it is 8 to 10% only the detection is late. But still we are seeing this many cases of death with the male, with the both the male and the female. But then just imagine in the developing world, and this is something that I created, that based on the outreaches that I have been doing since 2017, I'm going all across India to do the population outreach, to tell everyone, breaking the breast taboo, because we do not discuss about breast health. How many of us actually over here in our forum also went for your screening mammogram after the age of 40 and got detected? Those who have been doing, they're below 40 doing breast self exam, they could get detected early. So basically understanding the look and feel of our breast to detect any abnormality, that is so, so important. Now, when we are talking about the situation, current situation with the breast cancer advocates today here in the forum, we will also, whenever I talk about the detection, like self-exam or clinical breast exam or mammogram, follow-up ultrasound, that is needed even if we are having mastectomy, right? Because there are the collarbones, there is the underarm area. So these areas are also equally important. So please know that doing a breast exam, or like checking all these places, is very important once a month. But in the developing world, especially in India, the taboo and ignorance leads to the late stage detection, and also there is the lack of research, which I was mentioning earlier. Because I get very sad when I see that, when I'm looking up the PubMed and I see 60%, 70% is detected, like this is survival in India. But when I've been traveling all across those places, where a lot of families are telling me, not even the rural sectors, I'm talking about in the urban sectors, my friend passed away with breast cancer due to late detection. My wife passed away. So where is the data represented? And that's where we are trying to emphasize, even with the breast cancer hub. Now here is the male breast cancer, because I was told in the beginning, good that you brought it up, because this is my always I always mention that we always ignore the men. We never think, whenever we think of breast cancer, we are talking about women all the time. But though male breast cancer scenario is rare, it's 1 out of 833. But I always say that that person is a father, a brother, or a son of the family. So how can we ignore the man of the family? So always remember that for the male breast cancer scenario, it is very I do not approve it from my heart, because we are giving the same treatment that we have developed for the female scenario for the male also. And that is why, now the research that I'm doing with the male breast cancer, I'm seeing a lot of discrepancies over there. Because when I myself was running experiments in the lab, the preclinical study, we would always use the female transgenic model. And for the males, we would use for lung cancer, for pancreatic cancer, for other cancer experimentation. We never recognized that the male scenario should have been done with the male transgenic models. So these were the gaps that we have in our research, in our medical fraternity, which we should be speaking up for that. So here with the male, the scenario is worse than women. Men feel it's a woman's disease and they're more shy to talk about it. And the saddest story that I heard was here in the US, and this person is not there in the picture, but he told me that his own kids were bullying him, were teasing him, because उनके father को breast cancer हुआ है, सब लोग मजाक करेंगे उनका. So that is so sad, right? So you can imagine the scenario. I know someone from Nepal who committed suicide because he got breast cancer, because his friends were teasing him. Now, with male breast cancer, the youngest I have met is Brett Miller. At the age of 18, he fell the lump. And that's why it is so important that even the young population needs to do the breast self-exam that I'll talk about later on. So now, why the male breast cancer happens, right? That I'll discuss in the later half, about the genetics, about the environmental factors, about the occupation, and of course, there is a bucket which is still unknown. Now, what is cancer? We all, just to give a little introduction so that it becomes easier to understand when I'm talking about the targeted therapy and the immunotherapy, which are big buzzwords in the research domain, in the treatment domain now, right? So basically, cancer is a silent growth. Why? Because if we have, for example, when we have a COVID infection, our body is constantly reacting. There is an immune response to it. But with cancer, it is a silent growth because it's happening within our cell. Now, when because the DNA inside the cell, that actually regulates how many times the cell needs to divide. But if there is a mutation, that means if there's a change in the structure, the DNA, which is the main place which regulates the division of the cell, that's where the cells become abnormal and they multiply in an uncontrolled fashion. Now, just please know that even when they're multiplying in an uncontrolled fashion, not all the time it will be malignant, it will be cancer, because most of the time, 95% cases, it will be benign non-cancer. But please know, even if it is non-cancer, we have to do a diligent follow-up every 6 months with the with the breast scenario, or even if in the inside the, because breast is easy to detect, but if there is a tumor other areas inside the body, but still a diligent follow-up needs to be done, because there are chances that a benign tumor may also become cancer. Now, who are the drivers of cancer? So inside our body, basically, there are certain tumor suppressor genes. There are DNA repair system. There are many, every day, like as we grow up, our body is exposed to external agents, which we call, like carcinogens. They are getting exposed. We are in this world being exposed to many different carcinogens, which can cause the mutation, the change in the DNA of the cell. But inside the body, there are tumor suppressor genes. If any damage is happening, there'll be a repair mechanism. It's going to repair the cell, and that's how it gets protected. But not all the time we may be able to protect our body, and that's when, if the tumor, if there is a mutation, if there is a change in the tumor suppressor genes by itself or the DNA repair system, that's when the cell loses its signaling power. So basically, we have to, what do we do to take care of those within the cells? What can we do? If, of course, as I said, there it can be genetics, it can be family history, but that is only 5 to 10%. 80 to 90%, it can happen randomly to any person. So what could be those risk factors that also I'll talk about? But when I talk about that, you will see that from where it's the genesis is happening. Now, with breast cancer, Savita, keep me on check with the time, please. So with
Yeah, yeah, sure. Please
all
carry
right.
on.
So with breast cancer, what happens is, why that early, like the earlier we detect, the better the prognosis is. That means that we will be able to treat, like, for example, I'm not saying that I know patients detected at advanced stage, at stage 3, and then still, they are doing very good. They got treatment and everything. But in some cases, even when like 20 to 30%, even when detected early, I have seen, like, there may be a relapse in the coming years. But that also, like, we shouldn't be thinking about that as much, because we should also remember one thing, that those who are, in general, we all are at risk of breast cancer. 1 out of 8 women can get breast cancer because we have the breast tissue. And also, like, even if we do take care of one breast with surgery, or if we are having breast cancer, but the other breast can be at risk. So what do we do to take care in all this situation? Now, what happens is that is where your early screening is very important. That is the mammogram that we will be talking about. But then where does this breast cancer originate, right? Like, as with the male scenario, many have asked me, like, men do not have breasts, so why do they get breast cancer? But there are some tissues, at least, which are still there. And some men, they can have more like gynecomastia. Their tissues will be a little bit more where they can have it. And the genetics play a huge role with male breast cancer. With the females, for example, the females, that there are lobules and there are ducts, inside the breast. And we should always remember that these are the lymph nodes, like under the arm. So many times, what happens is, it takes a long time for the tumor to grow if it is a slow growing tumor. But if the tumor is very aggressive, then it is like we have to be very due diligent with our screening process. Now, for example, if the different stages of breast cancer are stage 0, stage 1, stage 2, stage 3, stage 4. Now, stage 0, we can detect, like, inside the duct if we are doing the regular mammogram, which is the X-ray of the breast, but also in addition to ultrasound, because mammogram may also miss our cancers if we have dense breast. Now, next is that from the duct, what happens is, if the tumor, it will have enough time, or it will be traveling through the lymphatic system or through the circulatory system to the different parts of the body. And that's when the problem arises, is that when it goes to the distant organ or it is metastasized, it's difficult to cure, but it is treatable. So that's where different, new targeted therapies, all of the new like monoclonal antibodies, and of course, like the different combination of chemos that we are working on. Now, this is a very important slide, because always I hear patients telling me that it does work with some other person. Why isn't it working with me? I always request, please do not compare yourself with another person, because I always talk, when I talk to the oncologist, everyone's treatment needs to be personalized, because there are so many variables that comes into play. For example, here I wanted to show you this very raw data. This is like from 2007. So I was working in Mayo Clinic over here. So I plated two, these both. So what you see here, यहाँ पे आप जो देख रहे हैं ये कैंसर सेल्स है, यहाँ पे भी कैंसर सेल्स है दोनों साइड में, लेकिन ये एक टाइप का ब्रेस्ट कैंसर सेल है, ये दूसरे टाइप का ब्रेस्ट कैंसर सेल है. तो मैंने क्या किया था, मैंने जिस दिन 7 नवंबर को 2007 को मैंने इधर 1 मिलियन ब्रेस्ट कैंसर सेल्स को प्लेट किया एक डिश में अलग से, और इधर भी 1 मिलियन प्लेट किया दूसरे टाइप का कैंसर सेल. सो व्हाट आई सॉ इन 24 आवर्स, नेक्स्ट डे में जब गई लैब में, उधर मैंने देखा, ये देखिए पूरा फुल हो गया विद द ब्रेस्ट कैंसर सेल्स, कैसे मल्टीप्लाई किया. लेकिन ये जो ब्रेस्ट कैंसर सेल है दूसरे टाइप का, इवन 2 दिन के बाद भी ये कन्फ्लुएंट प्लेट नहीं था, मतलब इट डिडंट मल्टीप्लाई एज फास्ट. सो व्हाट आई एम ट्राइंग टू से इज दैट आई हैव माई सेल्फ वर्क विथ सो मेनी वेराइटीज ऑफ ब्रेस्ट कैंसर सेल्स एंड वी हैव टू ट्रीट ईच टाइप very accurately, that is very very important, because the grade भी बहुत important होती है. कुछ कैंसर सेल स्लो ग्रोइंग होता है, grade 1, grade 2 means moderately differentiated, grade 3 is poorly differentiated. So हम लोग क्या करें, right? So what is the treatment scenario? The conventional treatment that we do is basically either we go for surgery, पहले करते हैं, अगर ट्यूमर छोटा होता है तो सर्जरी करते हैं हम लोग, अगर ट्यूमर थोड़ा बड़ा होता है तो न्यू एडजुवेंट थेरेपी जिसको बोलते हैं हम लोग, पहले कीमोथेरेपी करते हैं, उसके बाद ट्यूमर श्रिंक करते हैं, सर्जरी करते हैं, फिर देखते हैं जरूरी है क्या नहीं, नेक्स्ट कीमो राउंड, नहीं तो रेडिएशन करते हैं. लेकिन आजकल बियॉन्ड दैट बहुत कुछ वी हैव टू ऑल्सो टेक केयर, बिकॉज जब कीमोथेरेपी हमारी चलती है, सो दैट इज वन इम्पॉर्टेंट थिंग दैट यू हैव टू बी वोकल टू योर डॉक्टर्स को आपके मतलब आपको जाके डॉक्टर्स को थोड़ा पूछना होगा, क्योंकि मेरे पास एक क्वेश्चन भी आया था कि हमने इतना बार पेट स्कैन किया इन अ ईयर, हाउ मेनी टाइम्स इट इज एक्चुअली वी शुड बी डूइंग इट. देखिए, of course any exposure of the PET scan is not, we do not want it, but we have to weigh, हमें weigh करना है हमारे लिए क्या जरूरी है उस मोमेंट पे. तो अगर हमको ये ट्रीटमेंट हमारी चल रही है, so how do we know the body has responded or not? क्योंकि जो कीमो ड्रग हम ले रहे हैं उसको उसका रेस्पॉन्स होनी चाहिए, श्रिंक हुआ कि नहीं ट्यूमर, that follow up is very important, rather than not going for the scan and say thinking that I'm going to have the side effect of the scan. But just imagine, हमको वो we have to figure it out that chemo is responding or not. If not, then we have to change the chemo. Tabhi, because your body, so that's how our patients needs to be very clear and advocate, like, okay, what is going on, because there are so many varieties of the chemotherapy that is available. Agar kuch kaam nahi kar raha, body is not responding, then there's another group that of chemotherapy that you can do. And most commonly now what we do is the ACT chemotherapy, right? Adriamycin and cyclophosphamide, jo follow karte baad mein with paclitaxel. So that really works. It's a very strong chemo. But even then, there can be certain side effects जिनके body में नहीं ले रहा है. At that point, अगर side effects से आपकी body, because your body is already immunocompromised, right? So in that case, if the side effect is taking over your body, then definitely you have to either stop it for a little time, or you have to talk to your doctor about changing the chemo. So because there is a variety available in the scenario in the research field now. Now next is that हमारी जब कीमो हो जाती है, but there are different groups of breast cancer, right? हम लोग जिनको हार्मोन रिसेप्टर पॉजिटिव बोलते हैं, HER2 बोलते हैं, ट्रिपल नेगेटिव बोलते हैं. So हर चीज का कैसे टाइप का न्यू टारगेटेड थेरेपीज है, व्हाट इज अवेलेबल इन द मार्केट, आई एम गोइंग टू एक्चुअली शो यू एवरीथिंग. सो हम लोग हमेशा, जैसे व्हाट इज कीमोथेरेपी सिस्टमिक, दैट मीन्स हम जब कीमोथेरेपी ले रहे पूरे बॉडी में, इट इज गोइंग टू फंक्शन वेरेवर अगर सेल्स, कैंसर सेल्स प्रेजेंट है, it is going to kill that, take care of that, right? Now, but precision medicine means it's very targeted. There can be different type of precision medicine, precision drug. That means that जिनको हमारे जो जिससे हमारी म्यूटेशन होती है, जिस कैंसर के कारण हमारे ट्यूमर सेल में जो म्यूटेशंस है या बॉडी में जो म्यूटेशन है, अगर हम उसको टारगेट करते हैं, या जो सेल्स कुछ एक्सप्रेस कर रहा है हम उसको टारगेट करते हैं, that means we are more specific, and that is something that we call as the targeted cancer therapies, which are all part of the precision medicines. Now, targeted cancer therapy क्या करता है, that will block or turn off the chemical signal. नहीं तो protein जो हमारे cancer cells, they express certain proteins in high amount, like aberrantly express करते हैं. If something that should be expressed in little amount, it may express in a huge amount. So that can be, and if that is expressed, which is a good thing, so हम लोग उसको target कर सकते हैं if we are having the target for that particular protein. So basically this is one of the ways. The other way, stop making new blood vessels. जैसे ट्यूमर्स को दे नीड लॉट ऑफ ब्लड टू ग्रो, इसलिए हम लोग जब हमारी हीमोग्लोबिन कम हो जाती है, हम लोग हमेशा सोचते हैं कि क्या हुआ. So if there is a tumor growing in the body, it needs lot of nutrition, it needs the blood flow. So हम लोग अगर उस blood flow को बंद कर सकते हैं, that is another way. The other way is triggering our immune system, जिसको हम लोग immunotherapy करके बोलते हैं. So and then the other way is blocking the chemical signal, जो कि signals होता है ना cancer cells की growth के लिए, उसको हम कैसे block कर सकते हैं. Those are the targeted cancer therapy. Now I'm not going to details. So under targeted monoclonal antibodies, जो हमारी बहुत I have done a lot of work on that. That is another way, like very specific. But all this come together. Now coming together, I'm going to talk about the viable, the FDA approved, क्योंकि बहुत जन ने मुझे पूछा है, I got few questions also, कि हमारे पास options और क्या है. Whatever I'm giving you now is our option, or जो basically, and I'm going to divide it up into 3 types, right? Which is the hormone receptor positive, then HER2 positive and triple negative. So one thing is for sure, जब किसी का reports में देखती हूँ ना, when I see it is hormone receptor positive, I feel little relieved, because HER2 and hormone, we know we have the targeted therapy. But when it is triple negative breast cancer, जिनके पास basically triple negative, that means the hormone receptor expression is not there, then also the HER2 expression is not there, plus so we do not know how to target it, and research is still going on even now. So but for that group, we have to be more and more aggressive with the preliminary treatment, so that we overcome the relapse rate. So you see the difference, right? So please do not consider your situation compared to others, because it's always important that what is the grade, what is the receptor status, what is your own body status, how is your immune reaction to it, how does your body respond, how healthy you are, do you have any other chronic diseases, those, all of those has an effect on your treatment process. Now, what is the first, let me talk about the hormone therapy. Now, our cells, and those who are hormone receptor positive, you know that we are talking about estrogen and progesterone receptors, right? Now, for this, we know that drugs that we are using and we commonly give is basically the selective एस्ट्रोजन रिसेप्टर मॉड्यूलेटर, जिनको हम SERM बोलते हैं, टेमॉक्सिफेन नहीं तो फारेस्टोन. So tamoxifen is very common, that is being given premenopausal basically. Next, दूसरा जो होता है वो फास्लोडेक्स नहीं तो फाल्वेस्ट्रेन जिनको हम बोलते हैं, and that is SERD, that means that is very selective estrogen receptor degrader. It is going to go and degrade the estrogen receptor. और tamoxifen क्या करता है, is going to go and basically block it. It's not going to degrade it, but block it. So it's selective. Now, drugs that lower the estrogen, जिनको हम aromatics inhibitors बोलते हैं, these are the different types. Femara, those who are on Femara, Aromatics, Aromacin, these are different aromatase inhibitors. Lekin, for this aromatase inhibitors, it's very important that we understand that our estrogen level should be really, really low. That's why we always say that those who are at the menopause, जिनका menstrual cycle नहीं होता है, उनके लिए this is a better way for the hormone therapy. और जिनका हो रहा है, still what then the doctors, the oncologists would suggest oophorectomy, that means removal of the ovary. अब सोच रहे ना किस कारण ये सब, because यहाँ पे ये जो drugs है is directly going to lower the estrogen level. तो हमारे ovaries, right? So it's going to always produce the estrogen. So you do not want an overproduction of estrogen, and that's why you want that oophorectomy से removal of the ovary. Automatically the body will come into the menstrual cycle, menopause side thing, and then or we just do the injection with the with the all of that what we use at different varieties where we do the luteinizing hormone LHRH जो injection हम बोलते हैं ताकि हम period को stop कर सकते हैं. So until and unless we do that, it is not recommended as much to use the aromatics inhibitor because the functionality is different. So that is why whenever you're going through the hormone therapy, you will get these options. Please discuss, and anytime I'm also there, my email address will be with you all. If you need any guidance, I'll be always there with you. Now, next is that in addition to all of that, targeted therapy for hormone receptor positive जिनको हम लोग बोलते हैं CDK4/6 inhibitors, बहुत we are using it a lot. This is another thing. If you are not being discussed by your doctor, you can take this to your doctor, and that is more for the advanced. If your cancer has come back, or अगर आपका advanced हो गया cancer from stage 3 to stage 4, then you can use this in addition. So basically, this is like CD, like हम लोग इसको बोलते हैं the inhibitor, the kinase, the CDK4/6 inhibitors. What it does is that cyclin dependent kinase, there's a cascade of signal transduction going on in the cell, उसको जाके हम लोग inhibit करते हैं. And these are the different brands, Ibrance, Kisqali, then Verzenio. So this can be actually, this is approved in the advanced hormone receptor, but HER2 negative, जो कि सिर्फ हार्मोन पॉजिटिव होते हैं उनको ही. आप ऐसा नहीं सोचिएगा कि मेरे दोस्त को वो दे रहे मुझे क्यों नहीं दे रहे, because probably you are HER2 positive, then you won't be able to get that. Similarly, there are other inhibitors also in the market. So what they do is inhibit क्या करते हैं. So basically what we are doing here, there are certain proteins which are actually increasing the signaling pathway, so those proteins we are going and inhibiting it. That's the role of the inhibitor. So those are the advanced treatments that we can definitely do. And there's another hormone inhibitor, mTOR inhibitor. You can talk to your doctor, but these are the 3 inhibitors that is approved for the hormone receptor positive. Now I'll come to the HER2 positive, and I know many of you had I think one of you had the question about the new injection called the Phesgo. So I just want to tell you this. Once you see this slide, everything will be clear. I tried to make it in a very simplified way. So basically, HER2 means this is the protein which is expressed on the breast cancer cells, right? Now, when Herceptin came in the market after like few years back, it was a huge advancement in the science because we were struggling with the HER2 positive cancer patients, breast cancer patients. So Herceptin was the original brand, but then, similar versions. Now, when we say similar versions, basically it is doing the same activity, but structurally also it's the same. Maybe little bit here and there, the biosimilar thing is being changed a little bit, but it's actually doing the same work and function. And these are the different names that they have. Now, when we talk about trastuzumab and hyaluronidase injection, we call it as Herceptin Hylecta. So the different names are given. What is Perjeta? Perjeta is basically trastuzumab and chemo. So they have combined it together. So trastuzumab was the original, we call it as Herceptin. So basically trastuzumab is the brand name. So Herceptin is the brand name of trastuzumab, which is going and targeting the HER2 positive breast cancer cells. Now, when the trial was successful with trastuzumab with chemo, they named it as Perjeta. All right. Now, next is that what is Phesgo then? Phesgo is trastuzumab, then pertuzumab, and hyaluronidase injection, which is basically making it more receptible for the particular dose to go and target the HER2 positive breast cancer cells. You see the difference now. So this is what is available. The next one is again known as the Margenza, but this is again, it's a HER2 monoclonal antibody with a chemo, which is being used, which is being given for advanced breast cancer treatment. Now, what is then Kadcyla, right? So Kadcyla is again being derived from there. Basically, it is getting more and more advanced now. So first of all, it was only trastuzumab. Then we combined trastuzumab with other things. Now we are doing the end with chemo. We combined it. Now we are doing antibody drug conjugates. That means this connects the HER2 antibody to the drug amtensine with the trastuzumab. So it's basically, it is making it more targeted so that the chemo drug amtensin will be now going and directly being added to the hard to express cells. So that is what Kadcyla is actually doing. And this amtensin is a drug, is a chemo similar to the paclitaxel. So basically, this is what Kadcyla is. When someone asks me if there are other options, the other options we have is Enhertu. This is another one that is available. This also does similar function. It's the HER2 antibody, which is the trastuzumab. But here the drug that we use, the chemo, is deruxtecan instead of the amtensin. So basically what I would suggest is that if you think that your Kadcyla is becoming resistant, because a lot of times there is a limit, how much you can give. That's why to do the follow-up scanning, because if you're seeing that no, my cancer is if it is static, which is good, that means this is functional. But if you think that the size is growing big or it is not responding as much, switch to the other one, because there is another chemo drug attached to the trastuzumab. So this is how we have to be very quick with our thinking and tweak the drug here and there, because that will make a difference. Now the other kinase inhibitors with the HER2 positive are these ones, and I don't know if any of you are using it, but Ticarb, I think I saw the question with Ticarb. Yes, someone who is using Ticarb. Ticarb is again trastuzumab with the chemo drug capecitabine. And you asked that, I'm happy to see with your point that your lesion has decreased and it is steady, right? So I would suggest that please do not stop your treatment which is working, because something that is working means your body is responding. Please I know it's not easy to be on the treatment, but please, situation is such that you do not want to stop something now, because your lesion is still there. If it has disappeared totally, then you can go back to a low maintenance something. But till it is still there, that means it is there. It's not disappeared yet or not just gone to very minimal point, then please continue this, but do your follow-up scans to understand that your body is not becoming resistant, and you have the other options that I have laid down over here. Now you see, I hope it's becoming clearer. Now this was about HER2.
Dr. Lopa,
yes.
Yeah, Dr. Lopa, can we finish in next 5 minutes?
Yeah, sure. So then I'll just give a brief about what I have. So we have the targeted therapy for the BRCA mutation. For triple negative, this is where even Savita mentioned about the immunotherapy. The immunotherapy is approved now for the triple negative breast cancer. But what happens here, I would request that if someone is on that position where you want to do the immunotherapy with Tnbc, always try to ask your doctor that the PD-L1 protein is present or not on your tumor. And I do not see that, because that's the checkpoint inhibitor with the immunotherapy with Tnbc that you need to find out, because it shouldn't be a random thing that, okay, nothing is available, I want to do immunotherapy, because immunotherapy has its own side effects. So please make sure that your PD-L1 level is checked on your cancer tumor cells to understand. That way you will know your immunotherapy will work or not. There was one more question about the side effects, that when to call your doctor. I have listed this out. You can take a picture. So of course, like, side effects will be there. But if there is a persistent fever, that means because your body is immunocompromised, there may be some other infection going on. Please call your doctor immediately. Shortness of breath, and you will know, if you're feeling uneasy for a little bit longer time, do not wait for anyone. Just call your doctor or go to the hospital, because you do not want to take any risk. I'll not go into all of this, but I want to tell you this, something very important that I wanted to bring it up, because I have 2-3 minutes more. Now, family history. So in your family, if you have ovarian cancer or breast cancer, definitely you have to do the genetic mutation for BRCA1, BRCA2. But here is where the male breast cancer also comes into being, because if you know someone in your family, males who have in their history their mom or grandma having breast or ovarian, the men should also do the BRCA mutation testing, because they are not only prone to prostate cancer, but also digestive tract cancer, breast cancer, and other types of cancers. And nowadays, I always say to do the panel. It shouldn't be just the BRCA mutation, but you have to do the full panel, because there are high maintenance genes, there are moderate maintenance genes, high penetrance, moderate penetrance gene also. So please know, do not stop yourself with BRCA mutation only. There are P10, CDH1, TP53, and other mutation. And one more thing I wanted to bring into limelight is about the other chronic diseases, because many times, like this was my work which got press release, as Savita mentioned. What we discovered was that when we have inflammation in the body, for example, like arthritis, and if we have breast cancer, we have seen that the progression of the cancer is faster because of lot of inflammation in there and their pro-inflammatory cytokines. So I would request that if you have any other chronic disease in your body, please make sure that you take care of the disease, because it is very important that it shouldn't be like adding fuel in fire. Because when we have cancer, we forget the other underlying condition in the body, because that plays a role that will also interfere with your treatment sensitivity and specificity. And also, one more important thing I want to bring it up before I end, of course, the lifestyle and all of that, but I won't have time to talk about the signs and symptoms and the recurrence thing. But one thing I would request here, I have mentioned about the vitamin D and all of that, that once when you're going through the treatment, please make sure that do not go through any other supplemental treatment. Or see, I am totally in favor of Ayurveda, I'm in favor of homeopathy, but when you're going through the treatment of conventional treatment of cancer, we haven't done any research where we have seen that what is the cross reactivity. And also, lot of times here we want to kill the cancer cells, not to protect the cancer cells by rich antioxidant. So I always tell everyone, have the natural, keep a balance. If you're taking, I know turmeric is very good, but don't get capsulated form. Have the haldi at home, जो हम हर दिन हम अपने खाना में use करते हैं. Get the raw turmeric and use it in your diet. Keep a balance, because you do not want to strain your body at that point. So all these small factors makes a difference. So I had got other information too, but because of time constraint, I wouldn't share now, but I'll be open to questions now. But thank you so much, Savita, for inviting me, and also to be here among the esteemed audience of cancer survivors. Thank you.
Thank you, Savita and Dr. Lopa. Thank you so much. You're so informative. Can I start a question?
Yes.
Who's this? Sorry.
Sheila.
Okay,
I'm Sheila here.
Okay, you want to ask the question? Okay, I mean, you can ask, and
Yeah.
then I have a list, and then I'll pick up from there. You can ask.
Okay, I think you started the list. They might have asked first,
It's
right?
okay, you have you can ask now. Yeah.
Okay. It is about the mammogram, doctor. So I just wanted to know, mammogram is so painful. I have been avoiding a mammogram just because of the pain. And finally, I had to go through and it was detected that I had cancer. So I was wondering if only sonogram is enough or we need to go for mammogram.
Yeah, that's a very good question. I'll just I just have to show this, otherwise you will not understand why. I'll just take it to this slide here. So what happens, Shilaji, so mammogram is painful, definitely, but to understand, so this what you see is a structure, integral structure of the breast. So basically, to understand the tissues, to detect the specific tissues, how they look like, mammography is needed. But what we see nowadays is that even like especially our Indian women, even I have severely dense breast. So this, when we have dense breast in the mammogram, which our breast tissues are supposed to be fatty tissues. Fatty tissues means it will be black background. But when we have dense breast or fibroglandular tissue, it appears as white patches like this. So that's when, if we have a lesion, it's basically finding a snowflake in the snowstorm. That's why now I suggest that mammogram in the US has become redundant. We always go for 3D mammogram, which is the advanced form of mammogram. Now, since you have already done mammogram once, that way you know your structural integrity of your breast, right? You know the details of it, because the calcium deposition of all of that only mammogram can detect. But then I would always request to do an additional ultrasound. If you have a 3D mammogram, then it's fine. That way it is an advanced form of mammogram. But if your hospital care doesn't have a 3D mammogram, please, each of you should go for an additional ultrasound, because most of our Indian women, we have dense breast. And I know it is painful, Shilaji, but it's worth to take that little time of the pain. It's better to be safe than sorry. Yeah.
Okay. Thank you, doctor. Thank you so much.
Yeah, I hope it answered, Sheila. So I'll take another question. So one question, this is from one of our member, and the question is, from the patient. I was diagnosed with stage 2 breast cancer in May 2020, taken chemotherapy, surgery, and radiation. Then I was on target therapy, Kadcyla, and during target treatment, during this target treatment only, it has metastasized to brain and currently on oral chemotherapy since last 1 year. There are two medication, Dr. Lopa. I think I have sent this
Yeah,
question.
so I have this question: the lapatinib and
Yes.
and the
Yes.
capacitabine, right? So the
Yeah.
lapatinib, yeah, and she wanted to know that I think she was the case who I talked about. Basically, her tumor is now she had, is there any other option? And the tumor is steady now, right? Um,
Yes.
Yes. So I would definitely say that what you are, because you said initially you were on the cat cycler and still it has metastasized. That means you shouldn't go back to cat cycler. That means your body is not responding. And even though cat cycler is good for others, it may not be good for you. So if your lapatinib is a tyrosine kinase inhibitor, it has got a different pathway. So that pathway is actually responding to your treatment. Then I would request, please do that, because please go with this treatment that is needed now till your lesion disappears, and then you can go to a different regimen for the treatment process.
Okay.
Yeah,
Thank you, Dr. Lopa. And I think one other question she has added is that she's on some oral chemotherapy and how long she should take it.
yeah, I think that's the
Yeah.
same with the lapatinib, the
Okay.
capacitabine, right? That's the oral
Yeah.
chemo you are saying, right?
Yeah. Okay. Yeah. Yeah.
Yeah.
That's
So you
clear.
should continue this because it's working till it disappears. So do not take any chance, but keep the follow up. If it doesn't respond, then switch to something else. Do not keep doing that. That means your body, your cells are becoming resistant. It will be, it's mimicking the environment now. It's not going to, they are very tricky cells, right? So you have to know that, but you have to be smarter than your cancer cells.
Right. Right. Thank you. And there is another question from one of our member, that is, the patient is in stage 4 and she would like to know what regular investigation she should go through and in how much duration, and when should I repeat the PET scan as per symptom or once in a year is fine. I think this is the question most of
Yeah.
the patients have, like
Yeah.
how often we should do PET CT, and does it, this question is for stage 4, but I have another question for normal patients like who has recovered, but how often they can go for PET CT. And we do struggle when we ask to the doctor. Sometimes doctor says it's not needed, and we feel very, we don't feel settled. Then
Yeah.
how do we know that? So, what are the symptoms we should be looking at,
Yeah.
and how often we can ask that we should get our PET CT done?
No, that's very good question. So first and foremost, with stage 4, we have to be diligent, because stage 4 we cannot ignore by thinking that I don't want to do the PET scan. We have to know our body is responding or not. With the survivor group, those who have no evidence of disease, the NET. So for NET, I always request, because I don't, I'm like this, I always suggest at least do a scan once a year, at least the pelvic area, because breast cancer cells, their favorite place are the bones, the spine, the pelvic area. So that area scan is important. The lung you can do. If you do not want to do the PET scan because of the it's the positron emission, right? So then just do the CT, like the X-ray kind of thing, so which will also help you. But I prefer once a year at least for the NED, for at least for the next 5 years. After that, you can switch to once in 2 years or something like that. But the next, like basically from the time your treatment finishes, that next 18 months is very critical, and then another 5 years, another few years is very important. So be diligent that time. For stage 4, you have to be proactive. You just have to, as your doctor suggests, because you have to know your treatment is working or not. And how do you do that? Sometimes waiting for the clinical symptoms to surface, that becomes pretty late, where I see that when you have the clinical symptoms, the lesions are already there. That's why you're having those problems, on the liver, on the brain, or on the bones. So I wouldn't go that far. And that's why I'm also pushing towards little bit more invasive diagnostic screening for the follow-up cases.
Yeah, yeah. Thank you. And there is one more question. On continuation of the previous question. Uh, Kadcyla, if my pronunciation is right, that's a medication,
It's,
Kadcyla. Huh?
Kerala is totally fine. I mean, we all pronounce in different ways.
Okay.
Yeah,
Okay.
yeah.
So the Kadcyla medicine, yeah, one of the members, she's on this medication, she's HER2 positive, and she wants to know what kind of precaution she should take while taking this medicine.
Yeah.
And is it chemotherapy, or it's different than
The
chemotherapy?
targeted therapy, but what happens is, as I had shown with Kadcyla, I think they have added a chemo. So basically, it's a combinational therapy. So I would say that till your cancer, till your, because there should be a duration. You have to, if you're depends upon the stage. If you're not stage 4, then once you are NED, no evidence of the disease, you can stop and you can stay beyond the vigilance, like for some time more. But if you're on stage 4, then you have to really wait till your tumor is not there, because stopping the treatment, that means you are kind of putting your body at stake, right? I mean, if you're not doing the treatment, if you think that with the follow-up your tumor is not shrinking, talk to your doctor for a different different version of the of the heart to targeted therapy, so that we can switch here. And then I have shown also what are the others available, FDA approved, so there can be a switch, because it's the same trastuzumab, but it's basically tied up with different chemo. So if that chemo is not working, then go to the next one, if that is working. So that way, just not stick to something that you're comfortable with. If it's working, well and good. If it's not, go and talk to your doctor about that.
So this awareness actually really helpful in going back to doctor and ask, is it working, or I mean, of course, the reports would show, but discussion makes a lot of difference.
Yeah.
That what other
And you have to
medications.
be proactive, because many times, like with research, and there are certain clinical trials also going on. I haven't brought the clinical trials once, because I am someone who would not ask anyone to go for a trial until and unless it's very, very needed, because I don't want any experimentation on our patients. I though it is important for the research fraternity, otherwise how will you get those drugs in the FDA market, right? But if something is working for someone which is already under approval, you do not want to put that person in a trial. So please know that make an informed decision. Talk to your doctor whether your trial is needed or not. If it is needed, if there are no other options left, then you go for it. If it is not, then try for the already established FDA approved drugs, because I myself worked on all of this, right? So I know, and I'm a reviewer for the all these drugs also at the so that way I always check on all of this. The toxicity, it is so important that there is so much of toxicity that goes with all any of the drugs, right? The targeted or immunotherapy. That's why with immunotherapy I see left and right people getting immunotherapy, but will this work or not? Because you have to know the expression of the PDL1, because immunotherapy is targeting the PDL1. That's how it's going to function. That's when your body is going to give that response to put the tumor away. So that is needed. Yeah. I think I saw a question about male breast cancer screening somewhere popping up,
Yes.
right?
Yeah.
Do you want me to take it,
Yeah,
Sabita?
yeah.
Okay.
Yeah, I think you can. I mean, I have a few more questions, and probably then we can take this May breast cancer questions.
Okay.
Yeah.
Yeah.
So another question was from our member. I think it was on the chat box, that what does Tnbc represent in reports? And I think I know that. I mean, you can answer. What does Tnbc means?
Tnbc means, as I was explaining also in the presentation, it is triple negative breast cancer. So now mostly all our research we are doing on Tnbc, because we sincerely do not know how to target. Because, for example, when someone with hormone receptor positive, HER2 positive, once your treatment is over, for the hormone positive, you are on tamoxifen, you are on some targeted drug, right? But with Tnbc, we do not have anything except that we have the immunotherapy now, which is being approved, and it's being said that when someone is on stage 2 or 3, also with the ACT and with a very aggressive chemo, you can also do immunotherapy. But I have patients who there's so much treatment in the body that, they are lot of times they have to go to emergency, because but then this is an approved protocol. So Tnbc is something that means the tumor cells are not expressing the hormone receptor positive, that we say estrogen receptor, progesterone receptor, and also the HER2, the human epidermal fat growth factors. I forgot the full term. So basically, the HER2, the ER, and the PR expression is not there. So these are the three things, and that's why we call it as triple negative. And that's how we get this name. And sometimes, like many patients came and told me that, it's negative. I'm so happy. So, and my heart just sings at that time. I'm like, okay, I'm not happy. So, but still, it's not that TNBC. I have patients with TNBC diagnosed in stage 4. They have babies now. At 25, they got it. So it is curable. So do not think it that way. It is curable with the right treatment, with the treatment, proper follow up. Those who are in stage 4, please do not give up, because just do not give up. I'm telling you, you will be able to fight it out, because we have treatments. It is maybe to cure it in like this will be little difficult, but it is treatable, right? So we will walk through this phase together. So never give up on anything. Like if it was for me, according to the doctors, I would never have had babies. Like I have 2 beautiful babies now with no treatment, like God's miracle. So after everything failed. So but I did my own research for my body, so I knew what the problem was. I did a very so you have to know your own body to really really figure it out. So if something is reacting very bad, just tell your doctor, but do not stop your treatment, because you need that treatment, because without that it will be difficult. There'll be other forces telling you, come here, this is much easier treatment. Please do not go, because I'm not saying that 100% our this treatment will work. It will be everything, every case will be successful. But the other side of it, I have seen patients, early detected patients, progressing to stage 4 because they didn't want to go through the conventional chemotherapy. And and then also many during the treatment, they were taking the help of other additional supplemental cancer treatment, which is again not a good idea.
Right, right. I completely agree. I mean, there are so many things, and I don't know what to call it. A name of treatment. There are a lot of frauds happening, so we don't know what we are actually consuming.
Oh,
So
yeah,
better to
trust me.
rely.
In our BCH website, Facebook page, some people are recommending some medicine or something. I don't even know. I did a Facebook like, okay, this is a fake thing. I don't even know these people. They do not put it down. What can I
Hmm.
say? No, under reviews. They're like, so this is what is happening in this world. I mean, it's very sad.
Another question is from Sudha that she is on. Okay, uh, I got my periods after 3.5 years of the treatment for 3 months. It was regular then, and again it stopped. What should I do?
So, are you on any medication, like any
Okay.
hormone
Uh,
medication?
I'm sorry. I mean, if the member is in the group, I'm sorry.
Or she can just, I don't know where the.
You can, or of course, if I will take it.
Yeah, yeah. So Savita, take this question and you can
Yes, yes, I'll take it.
message
Yeah,
me, and
got
I
it.
will, or give me her number. She can
Yeah, sure, sure.
share my number with her. I can talk
I
to her.
think
Yeah,
I
I
think
have kept.
I think she's in the
I
group.
think she's there.
Yeah.
No, no, it's okay. It's okay. We'll take it later. Maybe.
Yeah,
I mean,
Okay.
oh, yeah.
yeah.
Um, okay. What kind of immunotherapy are available in India for TNBC?
It's the same PDL1, which is available everywhere. So it is the PDL1 for TNBC, which I mentioned, but make sure that you get your tumor expression for PDL1 being checked.
Hmm.
That is very important. Yeah.
Okay. So, on continuation of this previous thing for premenopausal women, even I had this question. So, how shall we go back and discuss our doctor to switch the medication from tamoxifen to letrozole, or how long? I mean, if periods are not coming back.
Yeah, if you're having period, don't worry at all. So your tamoxifen is fine. But if you're getting into the menopause area situation,
Yeah.
then talk
Yeah.
to your doctor about the aromatase inhibitor. So
Okay.
if you want to switch to that, because
Uh,
aromatase inhibitor, what it does, Savita, basically, it actually goes and directly lowers the production of estrogen. So estrogen, which is being expressed, aromatase is expressed by the fat cells. So though our ovary function, so why do we that like post menopause women are getting breast cancer, because we think that if it is hormone driven, a lot of women say that hormone means only ovary, right? But actually our fat tissues, fat cells, they have aromatics, which kind of helps with the production of estrogen. So what happens here is that when you are having a menopause scenario, it's better to go for the aromatase inhibitor, which will go and directly just stop the production of more and more production of the through the aromatase. It is going to inhibit the aromatase itself, so lowering the production of estrogen. So talk to your doctor about that.
Okay, so every follow-up we need to discuss. It's like it has not come back, it has not come, and what they have to monitor it, right? I mean,
Yeah, it's always better. Yeah.
yeah. And okay, Anuradha ji has asked another question. I
Um,
think any pathological investigation to be done. I'm sorry, Anuradha ji, I didn't get the context. You can ask.
yeah, you can directly ask me,
Uh,
Anuradha. Yeah.
Actually, I just told my history na कि I'm stage
Yes.
4 MBC patient. So I just wanted to know कि मैं once a year I go for PET scan. That's it. So I should go for some blood test or some other investigations like
Yeah, I would suggest, Anuradha ji, because now you are having, and which medication are you taking now for the hormone?
letrozole compound. Femara, I'm on Femara.
Okay, so I would say at least in 6 months, once in 6 months, Anuradha ji. That is better. If they do not, if you don't want to do PET scan, do a CT scan, something to, I just want, because where was your lesion detected?
It was in spine, 3 places,
Okay.
and with the bone involvement.
Okay, it will be totally fine, So basically, then do a follow up for that area only, the pelvic scan. So I think to be on the safe side. Yeah,
Thank
don't
you.
wait for 1 year.
Yeah,
Yes.
thanks.
Thanks.
And another question is how effective are circulating tumor cell test and liquid testing for monitoring cancer? I mean, you can also directly interact with Dr.
I
Lopa.
wouldn't. So I myself developed a CTC antibody test, and that was only 70% specific and sensitive. So I myself do not recommend that. So even like so that is needed. So what I'll tell you this. So the CTC, the tumor, circulatory tumor cells, what happens is there are certain proteins which are expressed in the blood, and that we capture, right? Now, to do the screening, which is the screening mammogram and followed with ultrasound, or to be making sure of all of that and breast exam, these are mandatory. So this cannot be replaced by CTC, because what we see, yes, definitely it can be detected, but that is not 100% sensitive and specific. So how can you take that 20 to 30% risk for that population where the CTC is not expressed as much with such tiny tumor? Because so what happens is in the bloodstream, when the tumor starts to grow, that's when overproduction of the protein, and that will be released in the bloodstream, right? Now if the tumor is this much, it is very directly proportional. So that's why, though they are CTC in the market, but I would say that, you can have it as monitoring. For example, CTC is very good to monitor. Like, for example, Anuradha ji, if you have done any marker for our breast cancer, for the I think that one is CA 15-3 or whichever your doctor is suggesting. So if it is coming up, right, and you are going through the treatment, if it is going down, or in from the beginning when you have the cancer, if it is low, that means your CTC will not be your marker to detect your response. But if it was low and it has gone up from the level, like, if it is 200, and then that means that it is upregulated, it is functional for your case. And then you have to do a follow-up. That means that you have to go next, is that, okay, next my blood marker test, if it is going down, that means my body is responding with the treatment. So you see, so it's basically, it is very much more, I would prefer that for my follow-up thing as one of the entities, only if it was shown to be high. Some are false positive, some are false negative also. So you have to be very careful in the beginning what was the marker rate.
Thank you, Dr. Lopa. There are a few more questions, but in interest of time, I think
There was
now
one
you
with
can.
the male breast
Yes,
cancer, right?
yeah,
And
we could,
yeah,
yeah.
and I'm totally fine with my time, Savita, because for me this is very important to answer questions. So, but I'll go with the male. So I'll tell you one thing. So we are the first ones to make a breast self exam card for men. So please, Savita, I will share the link. We have
Yeah.
it in 24 languages, and I'm so thankful to our volunteers. Ours is a volunteer-driven organization. So the village. So we run many villages in India. So go door to door for screening, taking patients, and also this works wonders in the local languages. So basically, how to do the breast self exam from the age of 17 to 18 for the men, we have explicitly mentioned it. Is the same protocol like the female. For the female, and it's for everyone. I just want to mention, you have to go for your screening, mammogram, ultrasound. Those who are young, please go to your doctor, ask the doctor for the men also to do clinical breast exam. I'm still fighting for this healthcare change policy in the US because no one does it for men, and that's why with men also the detection is always late in the US. So how to do the breast self exam for men? Pick a date in the month. For women, 7 days post menstrual cycle. If you're in menopause, pick a date in the month. Stand in front of the mirror, take both hands behind your head, look for any discharges, any abnormal discharge. It can be like a other than breast milk for women, and for men any liquid discharge, bloody discharge. Then around the nipple area, for men it is mostly found right under the nipple because there are some breast tissues right under the nipple area. For women, we have to be very careful from top to bottom in a sitting position, and mostly it works best in a hard floor. You take your hand behind your head and with 3 fingers from your collarbone. So never miss the collarbone, never miss the underarm, never miss the chest, full chest area. For men and women both, look for any like a marble. हम लोग बोलते हैं ना, हम लोग खेलते हैं marble. So hard like marble, and it slips in your finger. So this is something that you have to do every month to understand the look and feel of your breast. If you feel that okay, it is, just wait for a few days. It may be hormonal. If it doesn't disappear, immediately go to the doctor. Doctor may say ye dawai le lo, ye hormone treatment le lo, kam ho jayega. No, just do an ultrasound or a mammogram, not to take any risk. Now, if anything like redness around the nipple area, any crackled nipple area, inverted nipple, अगर suddenly आपका nipple inverted हो जाता है, अगर पहले से ऐसा था तो कोई problem नहीं है, अगर अचानक से हो जाता है, then report to the doctor immediately. There's another type of breast cancer called inflammatory breast cancer, like all red, suddenly it becomes red. So anything that is red suddenly, please do not neglect it. Painless or painful, doesn't matter. Lump, painless or painful, please report. And those who have gone through bilateral mastectomy, even then, the chest area, the rib area, the underarm area, please make sure you keep checking that. That is important. And for men also, breast self exam. And if you feel anything, go to the doctor, do a mammogram. That's it.
Okay. Thank you, Dr.
Yes,
Lopa.
yes, Mehul.
Yes, no, you are on mute.
Yeah, yeah. Sorry. Thank you, Dr. Lopa, for that detailed, answering that question in detail. I'm in the US and I'm a stage 4 throat cancer survivor. I'm in my 8th year of remission, and now I go annually for my checkups. If I find something unusual, I'm asked to go to my primary physician.
Mhm.
So I've done a colonoscopy kind of test a few months back because that was what he recommended.
Mhm.
But he has never recommended anything for breast cancer. So do I proactively go and ask him for some test, or I'm 48 years old now.
Mhm.
So
You have to, Mehul. Just first of all, do the breast self exam and talk to your doctor. Tell him that you tell him that you work with Breast Cancer Hub, and they work with male breast cancer. They have patients from the US who have. So why don't you do the clinical breast exam? Because we are fighting for that, Mehul,
okay,
and we are really fighting for that. Now, if the patients become proactive, probably the doctors will think now.
yeah,
Please tell the doctor, can you do my breast exam?
okay, I'll get that.
Yes.
Thank you.
Yes. Thank you. Thank you for stepping up.
Thank you, Mehul. And and probably I have few more questions, but I will get in touch with you, Dr. Lopa, because I think otherwise it will just keep going and we'll
Yeah,
watch the
but you are
time.
the host, and whatever you share, I have like I never keep anything for next 2 hours because so that I do justice
Okay.
to the
I,
forum.
I had I had one final request, doctor,
Yes,
for the group. You are so enthusiastic and all. So I just wanted to see you can provide the slides that you had made. If you could provide a kind of thing
absolutely.
that I can store in the file section of our group. Anyone can go in and refer that, and something handy that if they have some question, we can ask them. Hey, check Dr. Lupa's file, and
Absolutely.
if you still are not convinced, then we can try to reach out to you. Something like that. If
Yeah, yeah, absolutely, Mehul. See, only thing I'll not be able to share are the patient pictures and all that I have. So I'll take all those out. I think the vital information is what I put together for different type of breast cancer, what is FDA approved now, so that you have that as your reference. Then no one has to go back and look literatures. You can just go and look it
Awesome.
up.
Awesome. Whatever you think is fine.
Absolutely,
Thank you
absolutely.
so much.
No, no, definitely I do that. Yeah.
Sorry, we are running out of time, but I had a very simple question.
Yes.
Should chemo be done?
So my question is, how many chemos are you suggested?
8 chemos, and I've just finished my first one.
Okay.
So I've been told recently because I've got thin veins. That's what he told me, and I'm triple negative.
Yeah, it's better to do Diva. I think or many of us in the support group also we have the chemo. So yeah, definitely Diva is better to do because that saves. What happens is the infection rate is also much lower when you have the port done because it's like inside. So otherwise, a lot of times with the veins also or the peak lines also, there's high chances of infection. If your doctor is suggesting, please do that.
Thank you so much.
Thank you.
I have a question. Can I ask the
Yes,
Yeah.
absolutely.
Yeah. Yeah.
evening, everyone? My dear one, I'm not taking the name. उसके राइट हैंड साइड पे ये हुआ था, ट्यूमर हुआ था। उसके बाद डॉक्टर ने मेमोग्राम बोला, तो एम्स में दिखाया था। मेमोग्राम किया था, उसमें नॉन कैंसरस था। अभी जनवरी में किया, तो नाउ 3 मंथ्स हो गए। तो अभी जैसे वो हैदराबाद में है, तो उसको डिस्चार्ज हुआ निपुल से, ग्रीनिश टाइप का लिक्विड डिस्चार्ज हुआ। वहाँ पे एक है इंडो अमेरिकन, वहीं पे दिखाया, तो डॉक्टर ने उसको यूएसजी अल्ट्रासाउंड के लिए बोला, तो किया। तो उन्होंने पूछा कि हेरिडिटरी कुछ है क्या? तो ऐसे तो नहीं है, कोई फैमिली में कोई है, पर दूसरा ब्रेस्ट का नहीं है, कोई मेल मेंबर है कैंसर में अफेक्टेड है, तो उसका नाम नहीं लिया। तो उसने बोला नहीं, कोई नहीं है। और उन्होंने बोला कि अगर नेक्स्ट टाइम होता है डिस्चार्ज, तो आप हमारे पास आओ, फिर हम करेंगे मेमोग्राम, क्योंकि किया था जनवरी में।
अच्छा, तो
तो इसमें क्या सजेशन देंगे?
कोई बायोप्सी नहीं किया उन्होंने, मतलब दे वर श्योर कि वो
नहीं,
बिनाइन ही है? तो वो ग्रीन डिस्चार्ज
बिनाइन
के
है।
लिए कुछ बोला नहीं, क्यों निकला? कोई इन्फेक्शन हुआ
हाँ,
है क्या?
हाँ, हाँ,
कोई
बोला डॉट लाइन पे बंद है।
अच्छा, अच्छा, तो
हाँ,
फिर कोई इन्फेक्शन के लिए हुआ है तो एंटीबायोटिक्स या कुछ तो दिए होंगे उन्होंने।
नहीं, डॉक्टर कुछ नहीं दिए मेडिसिन, बोला अगर डिस्चार्ज होता है
ठीक है।
तो
तो
आइए।
फिर अगर वो लोग अल्ट्रासाउंड से उनको पता चल जाता है कोई भी सिस्ट, इफ इट इज अगर वो सिस्ट बायरेट्स क्या होता है उनका, मतलब अगर वो डेफिनेटली अगर लाइक मेलिग्नेंसी का चांसेस है, तो वो लोग रिपोर्ट्स में मतलब वो नेक्स्ट है बायोप्सी बोलते हैं। तो बेसिकली मेरे ख्याल से अभी भी इट इज बिनाइन, दैट मीन्स नॉन कैंसर, बट स्टिल मैं बोलूंगी कि एवरी 6 मंथ प्लीज उनको बोलिए नेक्स्ट आफ्टर 6 मंथ अपने आप से जाके एक अल्ट्रासाउंड कराने के लिए, ताकि अभी जो सिचुएशन है ट्यूमर का और उस टाइम में वो कंपेयर कर सकते हैं, वो ट्यूमर बड़ा हुआ या छोटा हुआ या सेम हुआ। एंड ऑल्सो वो जो ब्रेस्ट सेल्फ एग्जाम मैं सविता को I'll give it to Savita and then वो पोस्ट कर देंगे आपके सविता, you'll be able to post it.
Yes.
So आप बताएगा मतलब उधर पे जो भी लैंग्वेज अगर I don't know what language you speak, पर सब लैंग्वेजेस है वो डाउनलोड करके आप उनको भेजिए ताकि वो अपने आप से वो जांच कर सके। अगर वो फील करते हैं कि अच्छा इस मंथ मेरा ट्यूमर इतना सा है, तो नेक्स्ट मंथ मेरा थोड़ा बड़ा हुआ है, नेक्स्ट मंथ तो और बड़ा हो रहा है, देन आप 6 मंथ तक वेट मत कीजिए। 3 मंथ में खुद से मॉनिटर करके यू टेक योर डिसीजन एंड गो टू द डॉक्टर अगेन।
Okay, thank you, doctor.
Thank you.
Thank you so much.
Thank you. Thank you, everyone, and thank you, Dr. Lopa. Before we close, first I would like to invite Anuradha ji to give closing address. And Mehul, up the token of appreciation. You keep it ready. We'll do it after that. Yes, Anuradha ji, please.
थैंक्स डॉक्टर लोपा। आज का सेशन बहुत बहुत इंफॉर्मेटिव था। वी वर एबल टू नो कि कितनी सारी थेरेपीज टारगेटेड इम्यूनोइंस सबके बारे में उतने अच्छे से पता चला। मेल ब्रेस्ट कैंसर के बारे में आपने बताया, दैट इज ऑल्सम। और सबसे अच्छी बात जो मुझे आज के सेशन की लगी थी वो आपने ये बोला कि अल्टरनेट थेरेपीज के लिए अगर कोई जाता है तो उसके लिए हम लोग कोई रिसर्च नहीं कर रहे हैं कि एलोपैथिक ट्रीटमेंट के साथ कोई अगर अल्टरनेटिव ट्रीटमेंट के लिए जाता है तो क्या रिजल्ट्स हैं। तो दैट इज सच अ गुड पॉइंट कि हम लोगों को समझा सकते हैं कि भाई इसका कोई रिसर्च नहीं है, तो यू नीड टू फॉलो द प्रोटोकॉल कि आपको जो एलोपैथिक ट्रीटमेंट लेना है गो फॉर दैट। उसके अलावा फिर बाद वाली जो चीज़ें हैं आफ्टर द ट्रीटमेंट यू शुड गो। और आपने बहुत अच्छे से सारी चीज़ें हम लोगों को बताई कि किस तरीके से पूरा सेल्फ ब्रेस्ट एग्जामिनेशन करना चाहिए, सारी चीज़ें फैमिली हिस्ट्री है तो क्या क्या चीज़ें ध्यान रखनी चाहिए। जैसे मैं अभी तक आई वॉज सो वेरी कन्विंस कि मेरे को कैंसर हुआ है तो मेरी बेटी इज़ ऑन हाई रिस्क, बट आज आपकी बात से आई केम टू नो कि माई सन इज़ ऑल्सो ऑन द रिस्क फैक्टर, तो आई शुड टेक केयर की फैमिली हिस्ट्री है तो उनको डाइजेस्टिव प्रोस्टेट या ब्रेस्ट कैंसर होने के चांसेस होते हैं। तो दैट्स व्हाई आई आस्क्ड कि क्या आपको लेना है। सो इट वाज वेरी वेरी नाइस सेशन, वेरी इंफॉर्मेटिव, and would like to connect with you always. Thanks once again.
I'm always here for you.
Thank you.
Thank you, Anuradha ji. Thank you for summarizing all the, the whole session in very crisp and clear manner. And now I would like to invite Mehul, and Mehul would be presenting the small token of appreciation to Dr. Lopa.
Oh, that's so kind.
Thank you, Savita, and Dr. Lopa. You're an amazing person. Thank you. Many people who will again see the recording, and they're going to benefit, and definitely we want to reach out to you with many questions for help, and I'm sure you're going to help us. So
Absolutely.
this is a very small token on behalf of the group. Actually, you've done so much, but please accept this. I'll just share my screen and.
I get very no, being here itself is an honor. So thank you.
Okay, one moment. Let me know when you can see my screen.
Not right.
Yeah.
Okay, I'm sure everybody's on mute. Actually, I was getting more and more questions, Dr. Lopa, but I think it will really take more time. So I will get them connected with you in that case. Yeah.
Yeah. I'm struggling. Just give me.
You're on mute, Dr. Lopa.
Yeah, I said whatever way you feel good.
Yes.
I can answer definitely.
Sure.
Let me know if you can see the certificate.
Thank you. That's so nice.
Yeah, it's a small token, but
Thank you so much. Thank you so much. That's so nice. Thank you.
I will send it to you on your email also, Dr. Lopa. And please feel free to share wherever you want and on your social media. And we will be posting this video on our YouTube channel. And apart from this, I think we are looking forward for more such sessions with you, because I don't think even 1 or 2 or 3 hours are enough.
No, absolutely. And only thing Savita knows for everyone that I am heading out to India. अभी मैं 13 जून से अगस्त 20 तक मैं इंडिया में रहूंगी, तो उस टाइम में मोस्ट ऑफ द टाइम मैं गांव में रहती हूँ, विलेजेस में. I may be out of network little bit here and there. तो अगर मैं नहीं तो मैं within 24 hours I respond. So if I'm not responding, you will know that it's
No,
because of
so
that I'm nowhere in the network zone.
yeah. So what we plan to do is we plan to keep only one point of contact. Like Savita will be the point of contact.
Sure,
All
sure,
the questions will go to her, and then she will communicate with you
sure.
whenever, like, so
Absolutely.
that will be
Yeah, so
streamlined.
that you, yeah, so that you don't get overwhelmed.
Yeah,
So
yeah,
whatever
absolutely.
questions and queries I'm getting, I will screen and will send it to you. Your response, I will send them back.
Okay, okay,
Yeah,
perfect. Yeah,
yeah.
all right. Okay,
Thank you. Thank
thank
you
you
so much
so
and
much.
happy Survivors Day then
Happy Survivors.
everyone.
Bye, bye,
And
Krishna. Bye, Anjali ji.
bye
Thank you
bye.
so much.
Bye,
Bye
Thank you,
bye.
Lopaji.
thank you.
Love you.
Bye bye.
Bye. Bye.
See you soon.